Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Victoria Leiphart. She is board certified in obstetrics and gynecology.
And I'm going to talk about the different kinds of incontinence, treatment for incontinence, what you can do without medication, that sort of thing. And incontinence is, and we're only talking about urine incontinence today, and it's defined as the involuntary loss of urine. You lose urine at a time you don't want to. 80% of adults with incontinence are women. So this is much more common in women than men. It's more common in white, non-Hispanic women. It's less common in Hispanic women, in Black women, and in Asian women. 40% of women have had at least one episode of incontinence in the last year. And it's half if you're over 65. The rate of incontinence increases with age. It's pretty low when you're in your 20s and 30s, and it increases steadily with age. 14% of women overall have a daily loss of urine. That also increases with age, and it's more than 20% in women in their 80s. 40%, these two statistics are the worst. 40% of incontinent women consider their urine loss a major problem, and 40% of incontinent patients never bring it up with their doctors. So we as physicians are not doing as good a job as we should be of asking our patients directly, because oftentimes patients are reluctant to volunteer it, or they just say, well, I'm getting older, this is a normal part of getting older. They're reluctant to talk to us about it, and we as physicians need to be better about asking our patients about it. Not all incontinence is the same, and the treatment is different. And the most common cause of incontinence is stress incontinence. That's that loss of urine with cough and sneeze. Urge incontinence is also extremely common. That's where you feel the urge to go and you don't get to the bathroom in time before you leak. Overflow incontinence, functional incontinence are less common. Mixed incontinence is some mix of these. And I'm going to talk about each one of these one at a time. You guys can't read this. It says, urology department, can you hold? This is a very busy slide. You do not need to know all the details of all of this. To evaluate incontinence, oftentimes just asking the patient about her incontinence is all you need to make a diagnosis. If a woman leaks only when she coughs and has a full bladder, and she doesn't have urge and trouble reaching the bathroom when she has urge, she has stress incontinence. She has classic stress incontinence. If she has the urge to go and doesn't get there in time, but has no other symptoms, then she has classic urge incontinence. Sometimes it's not clear what kind of incontinence you have, and you need additional testing. You can measure how much urine is left in your bladder after you empty your bladder to see if you're completely emptying. That measurement is called a post-void residual, how much urine is left in your bladder after you void. There are other testing that can be done. If you have any concern that there might be bladder cancer or precancerous change or something like that, or other bladder conditions that cause inflammation and pain, you do cystoscopy, which is looking inside the bladder with a little scope. If you have a suspicion of kidney cancer, kidney stones, something going on with the kidneys, you can do a CAT scan. You can also have what are called urodynamics, and that's where you put a little catheter into the bladder and into the urethra, and you start filling the bladder very slowly, and you measure how much can your bladder hold before you start to feel the urge to void. You keep adding how much can it hold before you have such an intense urge to void you can't hold it any longer. And people who have urge incontinence will feel the urge to void at a smaller bladder volume, and that urge, and you'll see it actually on the measurements, they can measure bladder contractions, you'll see that the bladder is starting to contract fairly early on with only a small amount of urine in the bladder. So these are tests that can be done if you can't make the diagnosis based on talking to the patient, exam, that kind of thing. Most of the time, you don't need these tests. Stress incontinence, like I said, is the most common incontinence, and when you have increased abdominal pressure from coughing or laughing or lifting something or exercising, anything that increases that abdominal pressure pushes down on the bladder, and if the pelvic floor muscles are weakened, then you'll leak. And the pelvic floor gets weakened for a variety of things. Some of it is genetics. Some women just have weaker collagen there. Some of it is related to childbirth. Some of it is age related. We all get loss of muscle tone everywhere in our body, pelvic floor included, as we age. And obesity makes it worse, because if you've got more weight through the middle, there's more pressure on the bladder. And some women will leak only with an extremely full bladder, and it's an infrequent thing. Those women are not usually bothered significantly by their stress incontinence, but some women, every time they stand up from a chair, every time they bend over, anything that increases that abdominal pressure even slightly will cause leakage. So what do you do about it? First thing you do is strengthen the pelvic floor. The Kegel exercises, and I'm going to talk about those in more detail in a moment, are sort of our first line of treatment because they're simple, they're easy, and they work really well for women who have mild urine loss. And for women who have just mild urine loss, oftentimes just doing the Kegels is all that they need. Surgery is usually our last option. Weight loss, even 5 or 10 pounds of weight loss will significantly improve urine loss for women. And a lot of women will notice that their previously just rare urine loss becomes more frequent if they've, after the Christmas holidays when they gain 10 pounds, or after they've gone on a cruise and gained 10 pounds, and that they go back to baseline when their weight goes back to baseline. Smoking makes it worse for several reasons. Some of it is that the nicotine and other things in the tobacco directly irritate the bladder. But mostly it's that you have a smoker's cough, and if you have an intense, strong cough, you're more likely to leak. Heavy lifting, especially done incorrectly, can weaken the pelvic floor. If you're doing weightlifting correctly, where you're engaging your abdominal muscles, engaging your legs correctly, you actually strengthen the pelvic floor. But if you pick up something incorrectly, you can weaken the pelvic floor. Any kind of chronic straining, chronic constipation weakens the pelvic floor. Kegels. Like I said, this is where we start. The hardest part with Kegels is figuring out what the muscle is that you want to contract. And the easiest way for most women, all the instructions usually say, try to stop urinating midstream. I actually find that hard to do. I think the easier way to learn Kegels is to put your fingertip at the opening of your vagina and try to squeeze your fingertip. Either way, It's usually easiest to learn if you're like lying down with your muscles relaxed to isolate that muscle. And once you figure out where that muscle is and what it feels like to contract it, then you don't need the aid. You don't need to, stop peeing mid-void or anything else. You learn where that muscle is and what it feels like to tighten it. And then you want to work on perfecting your technique. If you imagine when you're sitting in a chair that you're sitting on top of a marble and you tighten your pelvic floor like you're trying to scoop that marble up and into your body and sweep it up and in, and you feel that lift of the pelvic floor. And you hold that for about 3 seconds, then relax for about 3 seconds. And you want to focus on only tightening the pelvic floor. Most women, when they do Kegels, they tighten up their buttock muscles or their leg muscles or their abdominal muscles. They're engaging other muscles. You want to figure out how to tighten up just that pelvic floor. Don't hold your breath while you're doing it. You want to be able to breathe while you're doing it. And you want to aim for doing 3 to 5 sets a day of 10 or 15 Kegels. And I tell my patients, more is better. You'll find that your pelvic floor is stronger as if you do them consistently. And for women who have modest weight loss and modest incontinence, oftentimes Kegels are all that they do. And women who have more significant incontinence, the Kegels won't resolve their incontinence, but it will improve it. There are other exercises you can do that improve your pelvic floor. Yoga and Pilates, anything that focuses on that sort of core strengthening muscles. When you're doing yoga, the other thing that really engages your pelvic floor, belly dance. When you're engaging those abdominal muscles, you can feel the core muscles engage as well. And so all of those are ways to get to a stronger pelvic floor as well. And I like this one. You can do Kegels anywhere, anytime. You can do it while you're on the phone. You can do it while you're in the car. You can do it while you're sitting at your desk at work. You can do them anytime. 4 more, 3 more. Keep going, ladies. You can do it. So nobody can look at you and tell you're doing Kegels. This is actually what the pelvic floor looks like. It's this whole series of muscles that wrap around the opening of the anal sphincter and the vaginal opening in the urethra at the very top. And that's Dr. Kegel. He's the doctor who originally came up with these exercises. He came up with them for women who had had babies to strengthen up their pelvic floors. Surgery. There are several different surgical procedures that can be done. With no treatment, the urine just goes straight out the bladder and leaks. If you do anything to kind of pull this bladder neck toward the pubic bone, then you reduce the risk of leakage. So all of these surgical procedures, that's what they're doing anatomically. Transvaginal tape, you make an incision in the top of the vagina right over the urethra, and you tuck this Teflon tape into either side, kind of right behind the pubic bone. It just kind of gives a little lift to that bladder neck. Colposuspension, you can do it laparoscopically or through a little incision. You actually take a stitch and stitch to the side of the vagina, either side, and just kind of lift up. So you're actually not going around the urethra at all. You're putting a little stitch next to the urethra and kind of lifting it up toward the pubic bone. And you don't actually, this looks like you're stitching it into the pubic bone. You don't. You stitch it into the ligaments on the side of the pubic bone, and that just kind of lifts everything up. So you're not putting a stitch around the urethra and you're just doing a little lift there. That's called a Birch procedure. You can do urethral injections. You put in polyacrylamide hydrogel, and it just thickens up the wall of the urethra and, makes it harder for urine to just pass involuntarily. This is a pessary that is available that you can buy over the counter, apparently, that you put it in place and it kind of lifts up the bladder neck. It fits in the same way as tampons. Some of my patients use tampons, but we discourage that because it can increase your risk of toxic shock if you're using tampons and you're not on your period. So this is a better, safer alternative. And this last one is called transobturator tape. Instead of going, kind of tucking behind the pubic bone, you actually, with your buttocks up, you go actually into the buttocks and put the tape in around that way. The transvaginal tape, there's a higher risk that you're going to poke a hole in the bladder or that you'll have voiding problems, that you'll have problems urinating afterwards. As you're putting this tape in, you're going kind of to the side of the bladder, and there's a risk that you'll poke a hole in the bladder. With the transobturator tape, because of the way you're placing it, there's more risk of hip pain, groin pain, thigh pain. With any of those tape methods, there's about a 2% chance that the tape will erode through into the vagina. And so instead of, vaginal wall covering it, you can actually see the tape. And in that case, if that happens, you have to take the tape out. The FDA's warnings about vaginal mesh, those were things that were used to treat prolapse, where the vaginal walls or the uterus were sagging down and typically sticking outside of the opening of the vagina. So you're stitching everything back up and lifting it up, but that has a very high failure rate. If you put mesh in that goes along the whole length of the front wall of the vagina or the back wall of the vagina, depending on where your prolapse is, you reduce the risk of prolapse, of failure, that after you've had prolapse surgery, you reduce the chance that you'll need surgery again. The problem is that those mesh devices that covered the entire wall of the vagina had a very high rate of erosion and complications. And the FDA has issued warnings that they should no longer be done. And the manufacturers that make those mesh devices have voluntarily withdrawn all of them from the market. So those things no longer exist. The transvaginal tape and the transobturator tape, the FDA, when they issued their warning about the vaginal mesh, they specifically said, we are not talking about the devices that are used for lifting the bladder neck for stress incontinence. So they specifically stated that their warning did not include these, because for these, they're smaller, and the part that is right next to the vagina is only about this big, and it's covered with vagina, and the rate of erosion and complications was dramatically lower than putting mesh that covered the front wall or the back wall of the vagina. And so those mesh products don't exist anymore. These do. And because these they've been around for many years, they've got a good long-term safety record, and the FDA specifically stated that in their warning, they were not talking about these. They excluded this from their warning. There are different brands for the tape. They're Teflon for the most part. If you either fail the procedure, you're still incontinent after the procedure, or you have a recurrence of your incontinence and have to have a second procedure done, then a lot of just regular gynecologists and regular urologists do these procedures. These are very common procedures. If you fail, or if you have a tape erosion or something like that, or if it's just your preference, you should see a urogynecologist. That is a gynecologist or a urologist who's had additional fellowship training. And there are also doctors who've had additional fellowship training in what we call advanced pelvic surgery. It's, these things, the fistulas, that's where, like, usually as a result of a childbirth, you get like a connection between the rectum and vagina that needs to be repaired, complicated vaginal surgeries like that. Those are the things that we typically are referring out. The urologists, though, do these procedures. We have 2 really good urologists in the group, and they do all of these procedures. And so there are a couple of the docs in my group, the gynecologists, that do it, but for the most part, most of us refer to the urologists. Urge incontinence. This is slightly less common than stress incontinence, but causes more distress for women. Women find this much more troublesome and are more likely to seek care for urge incontinence than for stress incontinence. Some women they just urinate more often. They have urinary frequency, and that will spill over into the nighttime. Getting up once or twice at night, that is considered normal. That is well in the normal range. If you're getting up 3 times, 4 times, 5 times, 6 times every night to pee, that is what we call nocturia, urinating at night. And if your bladder capacity is so small that you have to get up every hour and a half through the night, your sleep quality is terrible. Even if you're able to go back to sleep fairly quickly, it's still disruptive. And that's what we call overactive bladder. And overactive bladder includes all of these things. So if you're just urinating more often and are peeing at night, you have overactive bladder. You can have the addition of urgency, where you feel the intense urge to go. And that's when your overactive bladder is getting worse. And you have the urge to go and you have to run to the bathroom. You have to know where the bathroom is in Trader Joe's and at the mall, and you can't walk around all the way around Lake Elizabeth because there's not a bathroom on the backside. And, that's when it starts to interfere with your quality of life. And if your urgency becomes so severe that you're unable to get to the bathroom in time before you start leaking, then you have urge incontinence. So urge incontinence is a subset of this, which is a subset of this. But they are all part of that same process. And this says, how am I supposed to take a 2-mile walk when I can't go 2 feet without having to pee? And so, that's sort of how you feel. And, this is classic urge, like, I just have to get there. And as I said before, with all of these, you get that urge to void at a smaller volume, because if your bladder's working the way it's supposed to, it will fill to a reasonable volume, and from the time you feel that urge to go to the bathroom, you have some socially acceptable period of time to get yourself to the bathroom. If you have urge incontinence or just overactive bladder, you feel that urge to go at a smaller volume, and that time from urge to leak is a much smaller time. So if you don't get to the toilet right away, you will leak. And so that's part of that whole spectrum. Some women get to the bathroom, but you know, they still have, overactive bladder. The other thing is, there's a certain psychological part of it. One of my childhood memories is my mother putting the key in our front door and doing this, because being at the front door of her house gave her that intense urge to void, and she had to cross her legs, which, by the way, does work. Don't ask me how somebody got a grant to do this, but somebody measured urethral pressure and leak pressure in women who were crossing their legs, and that, in fact, works to prevent leaking when you feel that urge. But it was always, she put the key in, and that psychological thing, she was racing to the bathroom to get there on time. And a lot of my patients tell me that they'll get into the bathroom and be unable to get undressed fast enough to prevent leaking. That they can walk to the bathroom, no problem. The second they're in that bathroom stall, they have that intense urge to go, and they just can't even get their clothes off fast enough to not leak. Most of the time, this is idiopathic, no known cause. It just happens. It typically gets worse with age, and it can also be a nerve issue. I've got patients who've had strokes, who have MS, who have nerve damage from their diabetes, who have developed urge incontinence as a result of their pelvic floor nerve damage. The anticholinergic drugs are the treatment of choice for urge incontinence and for overactive bladder. And the most common is Ditropan, which is, the generic is oxybutynin, and that is the cheapest generally. Detrol is also generic now. Enablex, Vesicare, Sanctura, all of these drugs, this whole class of drugs. The drug manufacturers would like to tell us that you get less dry mouth with these. The studies don't hold that up. Dry mouth is a side effect of all of these drugs, and it is pretty significant dry mouth. For a lot of my patients who have mild urge incontinence, they start these drugs and then decide the dry mouth is not worth it. Some of my patients will take them if they're going to be out. So if they're going to be out all day, if they're going to be out with friends, if they're going to the theater, they'll take them. But otherwise, if they're at home, they don't take them because the dry mouth is so bothersome. So it is one of those drugs that it's not like high blood pressure pills or diabetes pills that you have to take the same exact time every single day. This can be taken on an as-needed basis. It works better if you take it every day, but I have a lot of patients who take it as needed. Weight loss reduces the symptoms of this as well. Don't ask me why, but it does. Kegels help, not because they reduce the urge or improve your bladder capacity, but because they give you a longer time to get to the bathroom. If you do surgery for stress incontinence, or any procedure for stress incontinence, you make urge incontinence worse. And there are dietary triggers for things that will irritate your bladder. Like I mentioned, tobacco irritates your bladder. It will make urge incontinence worse. Caffeine, alcohol, carbonated beverages. Some women are very sensitive to that. And so sometimes figuring out if any of those are triggers and giving them up will oftentimes, if you've got mild urge incontinence, will resolve it enough. Bladder training is also a simple and easy thing that you can do that helps with urge incontinence. Because some of it is just psychologically training your brain and your body, you can train your bladder. So what you do first is keep a voiding diary, and then that becomes your baseline. So if you're typically voiding every hour during the day, what you do with the bladder training is you lengthen that by 15 minutes. So you void every hour and 15 minutes, and you void to the clock. Even if you don't feel like you need to go, you void every hour and 15 minutes. When that is easy, you add another 15 minutes and you go to, an hour and a half. And if in that hour and a half you feel that urge to void, you try to take some deep breaths, you try to delay it as long as you possibly can. And you can, most of the time, you can get out to some more socially acceptable voiding pattern. Get out to voiding every 3 hours or something that allows you to live in the world and not have your life so dominated by your bladder frequency. And getting to 3 or 4 hours is usually what we recommend that people try to get to. Some people never get there, but for a lot of people it's life altering if they can get to 2 hours instead of every hour. And it's going to give them better sleep, a better ability to go grocery shopping, go to a movie, do those things. Overflow incontinence. That is when the bladder is over distended and it doesn't contract normally. So it can be because the bladder muscle tone is weaker. It can be due to medication. It can be due to nerve problems like diabetes. For men, it can be due to outflow obstruction from enlargement of the prostate. And it can also be due to nerve damage, like from a spinal cord injury or stroke. It is the least common of all of these incontinences and the hardest to diagnose because women oftentimes will describe just constant dribbling or a feeling that they're not emptying their bladder. Some women will void, stand up, and dribble. Some of that can be because you have a larger post-void residual and you didn't empty your bladder completely. Some of that can be because you've got overflow incontinence. Sometimes that's because you've got some vaginal prolapse, so that when you're voiding, a little bit of urine sort of sits in a place where the bladder kind of bulges into the vagina, and when you stand up, that will leak out. And some of this is that a lot of us just don't void correctly. The correct way to void is to sit and relax your pelvic floor and just let the urine flow out. Most of us void because we've gotten in the habit of being in a hurry, of sitting and pushing it out. And if you do that, you're not going to get it all out. It's only when you relax that pelvic floor. And in fact, a lot of people who've voided all their lives by bearing down and pushing the urine out, when they have surgery for stress incontinence, where you lift up that bladder neck, if you push down, it kinks off the bladder neck and you can't pee at all. So for a lot of people who've urinated that way all their lives, they have to learn how to void correctly after they have surgery for stress incontinence, because we're all in a hurry and we all sit down and push it out. And you have to relearn how to void if you have surgery for stress incontinence. But a lot of people don't get that relaxation of the pelvic floor, and so they end up not getting full bladder emptying. And some people just have a weaker bladder muscle, and they don't get that full emptying. There's really no way to sort out what's going on with a woman who has those symptoms without doing urodynamic testing and post-void residual. So you really have to, see either a urogynecologist or a urologist to have that kind of testing to sort through why you have that. If you are not completely emptying your bladder, you are slightly more prone to getting bladder infections. If somebody has obvious straightforward stress incontinence, their symptoms are classic or obvious urge incontinence, then you talk to them about treatment for those, especially non-surgical treatments. If somebody has more complex symptoms, like they feel like they're not completely emptying their bladder, or when they stand up, they still leak a lot of urine. If they've got something that suggests overflow incontinence or poor bladder muscle tone or something else going on, you'll typically refer them for urodynamic testing. The other issue with overflow incontinence, if you give somebody drugs for urge incontinence and they in fact have a weak bladder that doesn't contract well, you will put that woman into urinary retention, because the drugs for urge incontinence cause the bladder muscle to be more relaxed. And so if you've got somebody who's already got a distended bladder because their muscle is really weak and not contracting well, and you give her a drug that makes her bladder even more relaxed, the muscle more relaxed, that bladder will not contract at all, and she will not be able to pee at all, and will have to be in the emergency room being catheterized because she cannot void at all, and she has urinary retention. So if you even suspect that somebody might have overflow incontinence or not be fully emptying their bladder, you absolutely do not give them the drugs for urge incontinence. Functional incontinence is when your bladder works just fine, but you have a reduced ability to get to the toilet. And that can be because of mobility issues, because you've got arthritis, because you use a walker or a cane, because you've had a stroke, because you've had surgery and your leg is in a cast. It can also be due to cognitive issues, either because you have significant developmental delay or because you've acquired cognitive issues such as dementia. All of those can cause you to have incontinence, even though your bladder works fine. And I like this, disability awareness training. Just to make it more authentic, we'll add a bit of incontinence. So, if you're a wheelchair user, if you're a user of crutches, you may have a harder time getting to the bathroom before you're going to leak. And with dementia, you lose the ability to realize that your bladder is full and go to the bathroom. You lose that feedback loop. Mixed incontinence is extremely common. More than a quarter of women actually have mixed incontinence. It's about a quarter mixed, about a quarter urge, and a quarter stress. And of the mixed incontinence, any of these incontinences can be mixed, but for the most part, when we talk about mixed incontinence and use that term as physicians, we're generally meaning someone who has stress and urge incontinence. If both stress incontinence and urge incontinence are present, if they're both there, you treat the urge incontinence first. If they get adequate relief with treatment of their urge incontinence, you've saved the woman surgery, and you have prevented the risk that you'll do surgery for her stress incontinence and worsen her urge incontinence. So you always treat the urge incontinence first before you even think about addressing the stress incontinence. A lot of older, more frail seniors will have functional incontinence combined with something else. But in the general adult population, the most common mixed incontinence is stress and urge incontinence together. And it's quite common. And again, it's kind of this spectrum. You know, somebody can have stress incontinence and overactive bladder. So they may not have urge incontinence, but they have overactive bladder and stress incontinence. We would still consider that woman to have mixed incontinence, even though she doesn't have urge incontinence. She's at risk for urge incontinence because of her overactive bladder. This is actually a very promising slide. It's busy, but I'll sort of go through a little bit of it. There were two groups of incontinent women. Both groups were given information on Kegels and bladder training and avoiding triggers like tobacco and alcohol and caffeine. The treatment group got information on diet and exercise. At the end of 6 months, the treatment group had lost 15 pounds and the other group had lost 3 pounds. And 2/3 of the treatment group had at least a 50% reduction in stress incontinence and a 50% reduction in urge incontinence. But the data on lifestyle was also really good. So the treatment group is the dark, and here you've got 2/3 of the women who were at least 50% better for stress incontinence, and about half of them were 50% better. And they defined that as how often are you incontinent, basically. You know, so they were incontinent half as often with urge incontinence. But the group that got just information on Kegels and bladder training, they did remarkably well as well. They had a pretty significant improvement in their incontinence. You know, a lot of them got a 70% reduction. Not so many of them went from being significantly incontinent to not incontinent at all. But still, more than a quarter of the women who had stress incontinence went from significant incontinence to completely dry. And 2/3 had a dramatic reduction in their symptoms. But what I find really positive is that the control group also had pretty significantly good results. And these are things that have no risk and are accessible to everyone. And so this is where we start with all of our incontinent patients. Do the Kegels, do the bladder training, try to avoid the triggers, and see what that gets you. And for a lot of women, especially if their incontinence is on the milder range, this is enough. This gets them enough relief that they don't want medication, they don't want surgery, they don't want anything else. And so I really like this slide. The trouble with extra large coffee is I have an extra small bladder, you know. And to a certain extent, some of it is just having realistic expectations. I drink coffee every morning, and I just accept that the first 3 or 4 hours of the morning, I will pee every hour. And then I have a more socially acceptable duration of, you know, ability to hold my bladder as the rest of the day goes. And I like my coffee, so I'm not giving it up. And so some of it is having realistic expectations about, you know, how you live in the world with, you know, these symptoms. This is my final slide. When all else fails, you know, the little panty liners and the pads and the incontinence underwear are peachy, and they work very well, and they have improved dramatically over the course of the years. And do not buy products that are intended as menstrual pads. They're made differently. The incontinence products are all made with polymers that are designed for rapid absorption of liquids. The menstrual pads, you're not having rapid gushing the way you are with an incontinence pad, and they're made differently. And So you get less wet skin, less odor, and they're now making them with slimmer profiles that are more comfortable and all of that. So all of these remain an option. And I like this. Give me the best you got, laddie. It's comedy night at the rest home, and I plan on doing a lot of leaking. And this one, tacky but funny. They're adult diapers in a thong. I told you I was bringing sexy back. And he says, "Sweet angel of death, please take me now."